world. Welcome, everyone. I welcome you to the Asian Australasian Society of the Neurological Surgeons webinar. Today, it's on a broad topic of vestibular schwannoma. As you all know, it's one of the most favored indications for neurosurgeons, and among skull-based tumors, it still poses challenges to us, including our understanding of the natural history, management options, and its controversies. So today we have two world-renowned experts of this field today. I first invite Professor Basant Misra. He does not need any introduction. Sir is the Director of Neurosciences at Hinduja Hospital, Mumbai. He is ex-president of Neurological Society of India and many other professional bodies of national and international repute. He has the richest experience with both microneurosurgery and radiosurgery. In fact, he was the first neurosurgeon to start gamma knife radiosurgery practices in India. And without wasting any time, I invite Professor Misra for his talk on 30 years with vestibular schwannoma.
Okay, thank you, Manjul. I will share my screen. What happened to my presentation?
I think it's in the lower corner on the left side, sir. Right
Sorry?
side.
Left,
Lower corner
left,
on the right.
very left side on the right.
Near
Lower,
the
lower left on the right. Acoustic ANS webinar.
Right.
Yeah. Anyway.
It's very minimized. I can't understand what happened.
Sir, I think it's near.
I see it on your desktop, Misra.
Uh-huh.
It's in the most lower LAN on the right. There is an icon of your presentation is lying there. Left, down. Yes. Well,
Here?
No,
see
sir.
it.
Extreme end, sir. Extreme end on the opposite side near the recycle bin.
Opposite
It's on the
wing.
desktop.
Yeah. Just next to that. Yes.
No, that is a different one. That's not my presentation.
Go up a few centimeters up. You will see it. Yeah. Well, you skip. Yes, exactly. That's it.
You got it? You're seeing it?
Yes, sir. We are able to.
Okay. You're seeing my screen now?
Yes, we see your
Yes, sir.
screen.
Your screen is visible.
Okay. So thank you, Manjul, and thank you, AASNS, for giving me this opportunity. I said Manjul had asked me for 30 years. I made it 40 years because that's when I started the management of vestibular schwannoma in my practice. So before I go on to the topic, I would invite you all, my friends and colleagues, to join us in the next year meeting. This is, again, would have a lot of interest in vestibular schwannoma, of course, the Massin meeting, the Masjid Sami Society meeting. And of course, we are joining that with the International Conference of Cerebrovascular Surgery and International Neurosurgery Update, which many of you might have attended before. Between May 14 to 17 next year in Mumbai. So please join us. So we need to change. But as there is been a saying, if you want to make enemies, try to change something. And the other thing, the Bernard Shaw said, progress is impossible without change, and who can change their minds, who cannot change their minds, cannot change anything. So you need to change over a period of time. So these are the various strategies we use for vestibular schwannoma in our practice. The microsurgery has been there for more than 100 years, radiosurgery about 50 years, and the fact that many of these tumors can be just observed and not do anything has been last 25 years. But all these aspects and all these options are relevant in different scenarios. So this, I have a interest for a very long-standing interest of more than 40 years now. And this is a historical slide for me because the first patient when I was a registrar in UK in Edinburgh, where I could save both the hearing and the face in this patient. And this was presented in one of the combined meetings of Edinburgh and Newcastle in those times in 1986. And this in 1993, we published our first series when I was in Sri Chitra Trivandrum, 100 cases, consecutive cases. We had lost one patient. We had a very high total excision rate, but our preservation function of the facial nerve was not so good. So we have moved on. This is my experience, which one of my residents had analyzed till 2023. You can see there number of cases we have treated. This is a personal experience, and Manjul said we did the first gamma knife in actually not in only India, in South Asia. In 1997, January 16, or the first case was operated by us. That incidentally happened to be a vestibular schwannoma operated outside, residual recurrence, which we treated. So this is 2023. 2023, this is my number of cases, more than 1,000 cases microsurgery, and around 17 gamma knife. And the patients whom I had operated, 17% of the patients of my microsurgery patient have gone on to receive gamma knife in their course of follow-up. So the philosophy in our practice, microsurgery earlier on, my early practice time, it was mainly preservation of life. They used to come late, sometimes blind, raise intracranial pressure, shunt, and so on. And the next decade, the 1990 to 2000, we really tried to do a total excision. Many of these patients would not come back for a follow-up. So our main focus was trying to remove the tumor. The next decade, the new millennium, then the shift of paradigm and the functional preservation became a critical thing. But we attempted to do a total excision and functional preservation, with functional preservation being the focus. And we, of course, tried to do total excision most of the times. Now, the last 10 to 15 years, we have moved on a little bit. The functional preservation is still the focus, and we don't mind leaving some tumor attached to the nerves in order to achieve functional preservation, and we don't shy away to leave some tumor, because we know there are adjuncts are available. We know that many of these patients would not need adjunct treatment even if you leave some tumor attached to the nerves there. So in my practice, the one thing in microsurgery which has not changed over the period of time is all my patients have been treated by only retrosig approach. The other approaches we have not used, because we feel that all sizes of tumor, from intracanalicular to giant tumors, can be taken out by this approach. And one approach, you become an expert, is better than a jack of all trades. Hearing preservation is possible. And in vestibular schwannoma, the area of interest in the bone is a very small bone anchoring at the intra-auditory meatus. And once you decompress, that's the area you need to expose. So I don't find any extra advantage doing a extensive translab approach for this vestibular schwannoma, though we do it for some other tumors quite often. And so these are the things which has not changed: the retrosig craniotomy, the meticulous dissection, the monitoring, the BERA when the patient has functional hearing before we start the operation. We still have the problems of monitoring, the hardware dysfunction, especially in countries like mine. So you need to have options. Most of the time we drill the intra-auditory canal, and there may be some discussion about it. But we feel that total excision is possible and recurrence risk is much less, and good functional preservation is possible when we do the drilling of the intra-auditory canal. Some changes in microsurgical practice. We have tried many approaches, the positions, and right now we do only the lateral position. I'll tell you why. The semi-sitting position we tried, and we systematically, all the patients for a period of time, we did that. One of my residents were doing a prospective analysis of the complications, and we all know about the air embolism. But what was devastating, which was not in our control, was this patient. This was a giant tumor from Bangladesh, lady who had this tumor. We had everything good, and the patient woke up with a good normal face, but paraplegia. You can see we took the patient down from the theater to the MRI. There was the diffusion restriction there, so there was ischemia. There was a short period of hypotension below 90 in the systolic, and that's about it that caused the damage. So we emphasize in our theater, when you're doing a semi-sitting position, not only that air embolism has to be careful, you avoid hypotension. Systemic blood pressure should not come down below 100. So currently, Most of our patients have vestibular schwannoma, whether it's an intracanalicular or giant, we do in a lateral lateral position and not semi-sitting position. Now, these are the Coos classification, most widely used classification, and this is some essential steps in the giant tumors. These tumors staying in the tumor arachnoid plane, significant decompression before we try to achieve intraartery canal drilling. Again, as I said, we do drilling in most of our patients unless the tumor is destroying the intraartery canal, and using the endoscope to take out the lateral part of the tumor has helped in preservation of hearing when you are attempting it. Closure, airtight closure, reinforcing the closure with fat, which has reduced significantly our CSF leak rate. And I think this is something very, very important. So stay in the tumor arachnoid plane, avoid retraction, and that can help in all sorts of tumors, right? From intracanalicular tumor to tumor with COOS2, both tumors can be removed. And the important thing which we think is important is leave the arachnoid intact in small tumors. The arachnoid covering the normal structures is probably the best cover. You can see the end of this. I just want to show you at the end of this surgery, you can still the arachnoid intact. If I can go there, yeah. Fast forward, you see that arachnoid intact, and that is what we think, and this is endoscope assistance to take out the last bits of tumor. Now, COOS3, again, these are good tumors, and is a very nice thing to operate on these cases. And I want to fast forward. All right. Yes. I want to take this off here. How do I mute mine? Okay. So this okay. I just want to show you that it's the type of preservation in a smaller tumor is much better. You can see the nerves much better. The facial nerve and the cochlear nerve both can be preserved, and you have very good hearing preservation in small and medium-sized tumor when you do proper microsurgery. And if you preserve the hearing in microsurgery, that usually stays for good. That's what the literature says. But in spite of the fact that it remains good for a long time, sometimes it does drop over a period of years. And this is a lady which I operated 30 years back when I was in Trivandrum. And you can see over a period of time, 10 years down the line, her hearing drops. So it's not only in radiosurgery, but also in microsurgery. Even if you have a good preservation, total excision, then hearing can drop over a period of time. So this is the 98 we published that, but that is what we thought, that can we do better? Can you do a better preservation of the function? And then we did the pre-op MRI to DTI to wanting to find out where is the nerves, and that does help in finding out where the nerve is. So you're more careful. That's the fifth nerve, that's the seventh nerve. So you're more careful knowing where the displacement is. And that, I think, is been helpful. In giant tumors, we have found this useful adjunct of sodium fluorescein. The tumor enhances, the nerve does not enhance. But as we know, in large and giant tumors, every fiber looks like a nerve. So this is small adjuncts as a adjunct which have helped in differentiating one from the other. Now, one of the major problems in the hearing preservation in the small and medium and sometimes large tumors is its unpredictability. In microsurgery, in our hands, we can preserve the function in medium-sized tumors almost always, as in this case, but most of the time, it's not uncommon to have a drop of hearing. And that's what is a little bit bothersome, because you do have a preservation of hearing, but the hearing drops. Which are the risk areas? And now we all know very significant adherence, mechanical, just medial to the intraartery canal and meatus. The large and giant tumors, one other thing which does create that problem the sharp angle, almost 90-degree angle between intracanalicular tumor and the component and the extracanalicular tumor. So you lose the plane there. At the brainstem, it's the venous injury. Inside the interneural canal is the arterial injury and thermal injury because of coagulation. If you drill the labyrinth, of course, you lose the hearing. As opposed to microsurgery in COOS2 and COOS3 tumors, in gamma knife, there is almost always preservation of hearing immediately at least, which probably goes down after a few years, the hearing drops, but immediately 3 to 5 years, the hearing almost remains intact. And so that's a great advantage. Now, large and giant tumors, when there is, these are, since we are a referral center, we get referred many patients, and this is in fact a patient who have been operated outside. You see, this is first post-op, there's a huge tumor there, and we can always go back, and this is another one, we can go back and total excision, and this is another one, go back and total excision, good facial function. And when we have the tumor like this, small tumor remnant, we do gamma knife. Now, there are alternate options both for small, medium, and large tumors. Now, there's a lot of literature. I'll come to that. This is, we have seen it, that I think is just duplicate. So in large acoustic tumor, it is possible, but it is unpredictable. Now, this is some of these patients, giant tumors where we preserved hearing, but the problem is it is unpredictable. Now, the concept now, which is becoming popular, is subtotal excision and elective subtotal excision radiosurgery in all cases of large and giant tumors, COOS 4 and bigger. We don't agree with that concept as of now, at least, because in my practice, 17% that I saw, so 15 to 20% would only need that. And if we leave tumor, we don't need to rush. We can always observe for a period of time because many times the small tumor remnant may not grow. So if there is a high risk recurrence, especially multicystic tumor, young patient with a large tumor, giant tumor which has destroyed bone, we go for upfront. Otherwise, we always do elective follow-up. Now, this is, of course, the recent ISRS guideline. You can see that single fraction radiosurgery for large vestibular schwannoma, whether it is upfront or one which is left behind more than 2.5 centimeter, with significant good outcome, and they say that it is an appropriate possibility of doing that. Whatever you do, whether you do, this is Professor Yasserlil, who just recently passed away, the neurosurgeon of the century. This is a quote from him: be a frame-based surgeon or a frameless surgeon, don't be a brainless surgeon. So we need to be selective. We have to be, proper selection is necessary. As I said many times, when you leave a little bit of enhancing area in the MRI post-op, many times these are post-op changes, and sometimes this reduces and you don't need it. And when there is a long temporal history, patient who has 17-year, 18-year history of hearing disturbance, when you come to us, this is a 70-year-old gentleman with 20 years history of hearing loss, and he's a priest, a very important priest in India. So we did a subtotal excision. He never needed any further treatment. What happens if you leave some little bit of tumor? The tumor remains intact. This is a 20-year follow-up, no change. Post-op and 20-year follow-up, there is no change. So it's not always necessary to treat this upfront gamma knife. This is another patient when the post-op MRI high, increase contrast enhancements reduces over a period of time. Again, we have a significant number of patients when the enhancing component of post-op MRI 3 months either reduces or remains stable over a period of time. And the hearing remaining stable over a period of a decade or so. When we go for upfront, when there's a young patient, multicystic tumor, giant tumor which has destroyed bone, if you have residual tumor, we go for upfront gamma knife, as in this particular patient. Now, obviously, there's a lot of discussion, controversy, and interest in these two type of tumors, the COOS1 and COOS2, because both gamma knife, radiosurgery, any form of radiosurgery, or follow-up or microsurgery, all three are options which are appropriate. So these are some of the current guidelines or publications which I found. Upfront radiosurgery versus wait and watch, a scan approach. This was in JAMA. This is a major because this is a randomized study. And what they found, there was no significant difference in the hearing status when we waited. But the volume, upfront radiosurgery had a significantly greater tumor volume reduction. So they recommend that you should go for upfront radiosurgery for intracanaliculaire tumor, both for and small and medium tumors, rather than wait and watch. Now, my concern about this is this: if you wait and watch, there is no difference in the hearing status. They do need some patients would need further treatment, but 56 about so more than nearly 60% patients do not need any treatment. So you're 60% you're treating upfront who may not need treatment in their lifetime. So I would not say be very kind of hurry in treating this. And this, of course, Lunsford was one of the first to propose upfront radiosurgery when the hearing is good. And there are many studies have come up after that. And this is hearing data, long-term hearing data after radiosurgery is a meta-analysis in Neurosurgery 2023. The hearing preservation was actually no different between the observation group and the surgery group. No significant difference. And this is again the ISRS guideline in 2024. You can see they compared the radiosurgery. This was, I think, a critical review. And this radiosurgery, microsurgery, and the conservative surveillance, there was no significant difference in hearing preservation, tumor control compared to the surveillance. The radiosurgery, of course, the much higher control rate in the follow-up period, and the further treatment was significantly higher. So 25% of the people who were observed needed further treatment. What it means, 75% did not. So why do I have to treat that? I don't think it's appropriate for me to treat all intracranial tumor which are asymptomatic for go on to upfront radiosurgery or microsurgery. That's my view. Now, this is this just the opposite. Now, this is 2024, and this is a meta-analysis. And what do they say? The hearing preservation is better enough in observation group. The functional outcome is better in the wait and watch scan group. The PAN-QL, that's a quality of life score, is better in the wait and scan group rather than radio. So just the opposite than the previous data which I showed it. Now, the microsurgery in intracanalicular tumor, this is probably the best data, which is from Japan, which has never been probably duplicated. 80% hearing at 7 years and no tumor recurrence. So all patients had total excision, no recurrence, and 80% A and B hearing status. Very, very good data. And this is very close. 2016, Coldwell's group had published, and they had a preservation rate of about 75%, and subsequently they have published 78%. This is in 2023 Journal of Neurosurgery. The important thing to remember that the intracanalicular tumor, 22% of the serviceable hearing went to non-serviceable hearing. One of the problems when you operate, if you preserve hearing, that's good. But if you lose hearing, the patient notices it. Whereas in the observation group, the hearing drops so slowly, the patient never realizes that. And they listed out the critical factors which contributes to good hearing and bad hearing after intracanalicular tumor microsurgery. The preoperative good hearing, good for good preservation. The overlap between fundus and cochlea, if it is there, the worse hearing post-surgery. And these are the other parameters which are not that significant. These two are significant. And imaging characteristics, a large overlap that I said, and short distance between tumor and cochlear modulus, that increases the risk of post-op hearing loss in this. So does the gamma knife always controls? No, about 10 to 12% would fail even in medium-sized tumor. And this is one such example, 2.5 centimeter, multiple comorbidities, 70-year, which we did gamma knife, failed, and multiple cysts, a large recurrence, and patient was symptomatic. We operated. These tumors are the former almost white, remaining in the tumor at arachnoid plane is a little more difficult, but you can still take it out, most of the tumor. The key is to leave thin sliver of tumor attached to the brainstem and critical structure. You can still have good facial function. And we published that first in 2019, I think, and subsequently 2023. We focused on the cystic recurrence, how common was it? Now, the most disturbing fact is the risk of having a malignancy. Very low risk, but is still there. And this is one such patient published from our group in ACTA. I think it was 2023 we published it. The satisfies all the Cahan criteria. So we are very careful in young patients to advise gamma knife, especially if there is NF2. We would be very, very reluctant to advise radiosurgery for this. Now, how do they compare? The radiosurgery hearing preservation is a little better, but no significant difference. Malignancy, there does seem to be a little risk, especially in young patients, so one has to be careful about it. The minuses, the radiosurgery, you need to follow up because tumor is always there. Microsurgery, face weakness and complications are higher. And the other problem is the sudden loss of hearing, which patient notices. As up to observation, the loss is so gradual, the patient does not notice it. Of course, one has to realize for observation, the patient should be available for follow-up. If you lose for follow-up, then they come back with a large or giant tumor because 1/3 patients at least will fail observation in their lifetime. So in our practice, is total excision possible in large tumors? Yes, we do always internal aortic canal, almost always. Facial preservation is possible, of course, needs our experience. Hearing preservation is possible, but unpredictable. Monitoring is critical. So this is our paradigm currently for intracanalicular tumor. As I said, if they're asymptomatic, we always have a period of observation. If there is growth or hearing drop, or they're significantly symptomatic, especially vestibular, they go on to this arm. Now, they're deaf. We don't think we are doing great job by doing microsurgery. Risk of complications are always there, so they go for radiosurgery. If they have a good hearing in intracanalicular tumor, we still advise microsurgery because we think we can preserve hearing and there's a long-term hearing preservation is good. In extracanalicular tumor, less than 2 centimeter or 2.5 centimeter, earlier on we would say that you go for microsurgery, especially in young patient when there was good hearing. We have moved on because in our practice we have found, we have audited, we have published it. Our hearing preservation is worse in the small and medium CUS 2-3 tumors. In gamma knife, the hearing preservation is better. So today we say that if hearing is critical, the patient wants the hearing to be preserved, we would not hesitate to recommend radiosurgery, gamma knife, at least with the 40, 50-year-old people, rather than microsurgery. If the patient is deaf and is a small or medium-sized tumor, we advise microsurgery. Large tumor, critical, as I said, is functional preservation. Hearing is a bonus. We don't mind leaving some tumor because these tumors many times do not grow. If they grow, they can have an adjunct treatment. You can go back and operate or you do radiosurgery. Today, we don't think it is appropriate to have total excision or even subtotal excision with functional compromise. But there's a very difficult balancing act. The last bits of the tumor, when you're removing, we cause the damage. So that unfortunately comes with experience. But I think is important is to every time think, what would you do if he's your brother? And that is way one can go forward. The other problem with microsurgery is this is not literature, this is not medicine, this is not radiosurgery. This is a hands-on thing. There's no point quoting XYZ. It is your last 50 or 100% what you have achieved should dictate for the next patient. And there's no point following blindly. Thank you very much for your attention.
Thank you, sir. Thank you for this wonderful talk. It's really a very rich experience over the last 4 decades and change in the philosophy as well. So, sir, we will be having the questions at the end of the all three talks. And surgery remains the backbone of vestibular schwannoma. Our philosophy has changed dramatically from being life-centric to nerve-centric. Now I invite Professor Manas Panigrahi to share his insights on this topic. Professor Manas is currently the president of Neurological Society of India, a surgeon par excellence with great surgical experience and a wonderful mentor for generations of neurosurgeons. He is currently the neuroscience director of the KIMS group of hospitals in Hyderabad, and I am glad he has recently started gamma knife radiosurgery at his center. Over to you, Dr. Manas.
Can you see my screen?
Yes, your screen is visible, sir.
Okay. Thank you, Dr. Manjul, for giving an opportunity to speak on neurocentric approach to CP angle tumors. Professor Misra has already told everything, but then at the end he changed the philosophy that earlier for hearing preservation he used to tell surgery for young patients, but now he has changed that young patients needs to be observed, and elderly, and if they are deaf then they can go for surgery. I'm sure Manjul at later will tell that radiosurgery can preserve everything, all functional and no need of surgery. But then in between I'll tell whether is it worth preserving hearing in all the CP angle patients, because many times we discuss means facial preservation, there is no controversy, but hearing preservation we discuss so much. And what is the importance of hearing preservation, especially in the era of cochlear implant being very popular. The people are talking that when a hearing is preserved, one can place cochlear implant and then they can have a better life or a prolonged life, rather than uh, waiting. Means if you give radio surgery, the there is a hearing preservation for a certain amount of time, but they lose it. Whereas in microsurgery, immediately there is a loss, but then they recover to a certain extent. But the advantage with microsurgery is that one can go for a cochlear implant, and which can be useful for the patient. Whereas following radiosurgery, it is probably not possible to do a cochlear implant. Hearing is a major determinant in the quality of life, so it's very important as like facial nerve preservation, hearing preservation has to be done. But then the patient has to have a serviceable hearing, and many times for large tumors, serviceable hearing is not there. There are many reports, Professor Mishra said, of hearing preservation in intracranial tumors, but then there are few reports of hearing preservation in large tumors. The most important is one should have a serviceable hearing. What is the definition of that? The basic definition is that is the person patient is able to use his telephone, and if he can use his telephone, he should be able to use the telephone after treatment, whether it's surgery or radio surgery. And the basic definition of serviceable hearing is somebody should have a PTA of 50 decibel and a speech discrimination score of more than 50%. It is probably easy when you have a smaller tumor of less than 3 centimeter to make a decision. But then if it's a larger tumor, the decision changes, as Professor Misra has also explained in his algorithm and in his experience, that the decision not only depends on the size but also on the age of the patient. If one looks at the radiosurgery outcomes of hearing preservation, one can see that the hearing preservation it is better in the first 2 3 years, but over a period of time in radiosurgery, it falls down. And especially if one looks at Proton, the radiosurgery preserves the hearing preservation for over 5 years. It's worse than even microsurgery. And in radiosurgery, it is like 60% preservation in 60 to 80% in over 5 years. Um, that was in the smaller tumors, but in larger tumors, the preservation has not is just stable, but is not improved. And as you can see here, with large tumors, also the hearing preservation is there, but over a period of time they worsen. Unlike in hearing preservation after surgery, though it is in smaller tumors, hearing preservation has been to the extent of 40 to 50% in best and the best quoted literature is 80%, as Professor Misra told. But the general dictum is 40 to 50% preservation if when the size of the tumor is less than 20 millimeter. The basic difference between hearing preservation in microsurgery and radiosurgery is radiosurgery, the hearing preservation reduces over a period of time, and over 5 years, over 10 years, it because of the radiation induced changes, the hearing loss is more. Whereas in microsurgery, initially there is a drop, but then if they improve over a period of time. So hence, functionally speaking, one can go for cochlear implant in a microsurgery, but in radiosurgery, probably cochlear implant will not be useful as they deteriorate over a period of time. We took out just data to know how many patients actually present with hearing loss in our patient, and we had in last 8 years of 322 cases, 82% already had a hearing loss, and tinnitus was there in 11%, and only patients who had preserved hearing was only in 10 to 18%. So, and serviceable hearing is probably there in 7 to 10% of the patients. So what we are looking at is 7 to 10% of people who come with some amount of hearing preservation, serviceable hearing, what can be done from them. The mean size of the tumor what we operated was 3.8 centimeter. All of though pre-operatively we explain all of them that there may be a temporary loss hearing. We do not promise that you can save hearing, but at least we try to save. Aim is to save the cochlear nerves. If the cochlear nerves are saved, then probably they can be salvaged by doing a cochlear implant. Now there are few papers on unilateral hearing loss and using cochlear implant, and it though there has been difficulty for the patients of coordinating the binaural speech recognition, but then over a period of time they get rehabilitated, they get used to, and then that at the end they feel that it is has been helpful for them. In addition to the hearing improvement of the hearing loss, they also have a recovery of the vertigo. The vertigo also, people who have persistent tinnitus, that also comes down when somebody uses a cochlear implant. Though we do not have experience, our ENT surgeons are after us to give them a case, but we have not found the right case to for a cochlear implant in patients with which whom we have hearing preserved or they have persistent tinnitus. There are many case reports of people implanting cochlear implant during vestibular schwannoma surgery, and so that is what is coming up. And in those patients, they found that the speech discrimination improved. So during the CP angle surgery, small tumors, one can place a cochlear implant so that it will improve the hearing as well as the speech discrimination. But then it also can be done as a second stage procedure also. And on this paper, they said not only it improves hearing and tinnitus, but also improves vertigo also in patients with vestibular schwannoma. So it's important that patients who come with a serviceable hearing and tinnitus, we also try to explain that hearing preservation has to be done. The Gardner-Robertson scale was not elaborate, and hence it is better to use the Fukushima scale, where they have divided into 6 grades, and A to A, B, C, D are the grades which probably can be, one has to attempt hearing preservation and rehabilitate hearing by preserving the cochlear nerves and giving them the option of cochlear implant. So the aim of surgery is cochlear nerve preserving rather than only hearing preservation. Of the 47 patients we had operated, we had more than 39 patients had more than 3 centimeter size, and only 11 of the patients had some hearing preoperatively. This is one case of a 32-year-old female who had a vestibular schwannoma on the right side, more than 3 centimeter size. We do a routine monitoring. You here can see the picture that the aim is to preserve arachnoid and preserve all the nerve fibers along with the facial, vestibular, and cochlear nerve to find the plane. Preserve, as you can see here in the picture, preserve all means every small fibers so that later it can be used for cochlear nerve implantation. So this is the tumor. We use fluorescein, as Professor Misra has published a paper. The fluorescein helps in having a contrast recognition between the tumor and any nerve fibers. Sharp dissection using a needle dissector helps in a better plane and avascular plane of cleavage. This is a suction irrigation system which we have published that it irrigates and sucks at the same time, and which can be done with the locally available instruments, and it is very cheap. So it gives a very clear cleavage plane between the tumor and the nerves. There's again a larger tumor, 25 but 25-year-old lady with preserved serviceable hearing, and this is the picture using fluorescein. One can see that the nerve and the tumor, there is a contrast difference, and preservation of the nerve is better when one uses the fluorescein. And the preservation of the brainstem, preservation of the cochlear nerve fibers, all are clearly seen when fluorescein is used. And this is again the picture showing the brainstem and the tumor while dissecting. So all the whole nerve complex, the vestibular, you can see here the facial and the vestibular cochlear nerve complex has been saved in this kind of tumor. Of the cases we did, we attempted hearing preservation in 11 cases, and uh, out of that, more than 4 centimeter, also we had cases 18, and pre-op serviceable hearing was there in 5 of them out of 18. We could preserve in 2, and when the size of the tumor was between 3 to 4 centimeter, 6 had pre-op serviceable hearing, and 3 we could preserve. So the cochlear nerve preservation rate or the hearing preservation rate was 45% in our hospital. Now, this is the pre and post op. There is a preservation of the low frequency, there is a loss in the high frequency, but the patient could use that, and this is a scan after 1 year. And though there is a small bit of tumor there, we usually put fat in the IAC, and we do MIP index, and we have published that if the MIP index is more than 3%, they have a chance of recurrence. For them, we give upfront radiosurgery. But 90% of the time, even if you find a tumor, we do not give radiosurgery. And many a times, they actually shrink in size and become smaller. Now, this is another 44-year-old female doctor, and the the tumor had a gross total excision, which was a small piece of tumor in the canal, and this was the audiometry pre and post op at the end of 3 months. This is again another case, 50-year-old male with a large tumor, and this is the post op audiometry after surgery at the end of 3 months. And the scan shows total excision of the tumor, except a small and hyperintensity in the IAC. This is a pre and post-op audiometry of the same patient. This is another case where the pre and post-op audiometry shows that there is a drop in the hearing. It is not useful because all of them we could not preserve hearing, but there's a small piece left in the canal. And as I told, 90% of them do not grow in size. And this is a case of worsened hearing. We tried to attempt, but then the hearing worsened. This is the 7th case, again with preserved hearing, with audiometry showing the preserved hearing. We normally do the hearing test at the end of 3 months. Now, if you look at literature, it is also literature that says that it's 40% of the time one can preserve hearing in larger tumors also. Now, the key procedure for hearing preservation is to do a bloodless dissection, have a continuous irrigation and sharp dissection, and do debulking, capsular elevation to locate the facial and cochlear nerve, rather than facial nerve or cochlear nerve being dissected of the tumor. Electrophysiologically and visual observation is important, and avoidance of heat and mechanical injury to the nerve. while drilling the internal artery canal. Hence, uh, if the pre-op scan shows the internal artery canal diameter is more than 8 to 10 millimeter, we try to avoid drilling the internal artery canal, as we believe that the drilling of the canal, the increase in temperature probably causes thermal damage, and hence the hearing preservation will be less. So we have been avoiding drilling of the ISC whenever the ISC is widened to preserve hearing. This is one of the videos where we dissect the tumor. We, uh, the tumor and the facial nerve is, plane is identified, and the tumor is delivered from the fundus, from the IAC, like we do in pituitary tumor. We try to avoid drilling so that to prevent the thermal damage to the nerves. So this is like doing a endoscopic pituitary, take out the ISC part of the uh, tumor. And at the end, you check with the endoscope. If anything is left out, that part of tumor is removed. So with the endoscope check, if anything is left out, it's dissected from the nerves and taken out. This is again another case where you identify the plane and between the nerve and the tumor. Under endoscopic guidance, take out the tumor from the IAC. So this is the seventh and the vestibular cochlear nerve. Still a small piece is left. Here all the cases means here IAC drilling is avoided because it's the IAC is already widened by the tumor. So try to avoid touching the nerves and only remove the tumor away from the nerve. So mechanical damage to the nerves can be avoided. This is the final bit of tumor from the fundus has been removed. So the prognostic factors for hearing preservation, if you have smaller size tumor, it's easy. If you have a pre-op serviceable hearing loss, then one has to attempt. It also depends on the pre-op BAR quality and the duration of hearing loss. If the loss is very long, is short, then it is better. And younger patients and experience of surgical experience also helps in preserving hearing preservation. In our hands, avoiding drilling of the ISC whenever it can be avoided has helped in hearing preservation or nerve preserving both facial and the cranial and the hearing preservation. In conclusion, cochlear nerve preservation should be attempted for better rehabilitation so that one can think of placing a cochlear implant in patients who have hearing preserved and especially young patients. Thank you for your attention.
Thank you, Dr. Manas, for this wonderful talk, especially your mentioning about the cochlear implant, which is actually the vestibular rehabilitation, auditory rehabilitation. So we'll have the questions in the end, and I encourage the attendees to post their questions. We'll have it after my talk. I'm actually the last speaker. So I'll share my screen now. Is my screen visible?
Not yet.
Yeah, screen we can see.
Yes.
Yeah, all
Thank you.
good. Yeah, we can see it.
Thank you, Dr. Misra and Dr. Manas, for these wonderful talks. I was assigned the responsibility to find the topic for my own talk, and then I realized that I have put my foot on the landmine because the market is buzzing with new machines every now and then under the umbrella term of the radiosurgery. Everybody says they treat it, and they tell that they treat it in the best. So I've been practicing MRI for more than a decade, apart from my microneurosurgical practice, and I have an experience on working both 4C and the perfection machine. There is no financial disclosure for this talk, and I would appreciate your queries and comments at the end of. So, before embarking on SRS for vestibular schwannoma, there is a common understanding. Stereotactic radiosurgery is delivery of the high dose of radiation without opening the skull, but with a surgical precision. Now, up to 5 fractions is considered under the definition of stereotactic radiosurgery. More than 5, it becomes stereotactic radiation therapy. And as you have heard in the earlier two talks, the cochlear dose is actually a determinant of the hearing outcome, and we try to keep it minimum. There are various ways: maximum dose to cochlea, average dose to cochlea, mean dose to cochlea. And the serviceable hearing, when you have pure tone audiometry, less than 50 decibel, and the speech discrimination score more than 50%. But on a practical term, if the person is able to hear and talk on the phone from that ear, he is having a serviceable hearing. The radiosurgery market is extremely competitive now. It has become difficult to actually remember the names of various vendors and the machines and their specific parameters. Every machine has something good to offer and lack in certain other aspects, and that's the beauty which is keeping this market so much competitive. And machine and every treatment is a game of hit and miss, hitting the right target while missing the rest. While working in neurosurgery, you become obsessed with the precision, precise to target, sparing the organs at risk, minimizing treatment time, making the treatment in the minimum possible duration of time with the minimum radiation delivery time, and while ensuring the comfort of the caregivers and the patients, and while minimizing the chances of complications imposed by the radiation. So we try to minimize the radiation-induced complication in these patients. The stereotactic radiosurgery platform, by any platform, may suffer from inaccuracies, right from image acquisition to treatment planning to radiation delivery at the correct spot. And the weakest link in this chain varies from platform to platform. One of the most important link is the precise dose delivery. And once the machine has some inaccuracies, the clinicians try to add the margin to their target, and that may lead to the complication. Otherwise, in vestibular schwannoma, it's a contrast enhancing tumor. We just try to limit ourselves to the tumor margin. But if the machines have some inaccuracies, to cover up those machines, certain LINAC-based principles try to add the margin in those ones. There is a certain difference. How does a neurosurgeon look at radiosurgery and how does an oncologist look, especially when you're treating a benign disorder like a vestibular schwannoma or a meningioma? As in the earlier two talks, we heard that complete removal sometimes is not attempted when the tumor is in the internal auditory canal and we try to preserve the functional hearing and the facial nerve. So in those cases, we consider removing the maximum part of the tumor, leaving a little bit behind is not going to create a trouble. But an oncologist, by their usual under their philosophy, they try to target each and every cell, each and every part of the tumor. And to cover that, they try to add some safety margin. But adding a margin to your target suddenly doubles its volume. And doubling the volume increases the radiation dose at the periphery of the tumor, your target, and leads to the radiation-induced complication in those patients. Adding a margin is actually killing the Noren's policy. What is the Noren's policy? Noren's policy is to give the minimum possible but effective dose. If we add one margin, 1 millimeter margin, we are suddenly adding high dose radiation at the periphery of the tumor. And this may create a complication. How does it create a complication? In a vestibular schwannoma, you know that the facial nerve, trigeminal nerve, they are sometimes at the periphery of the tumor. With the DTI-based planning, you can actually identify the nerves at the periphery, and then you just try to do a sharp dose fallout at the periphery of the tumor so that your nerves at the periphery get the minimum radiation exposure, and that does not lead to any cranial neuropathy in those cases. If you add a margin, then these nerves are unnecessarily getting exposed to the high dose of radiation, and that translates into the complications in the form of facial nerve paralysis or trigeminal neuropathy. Let's first start with the safety, and the safety starts with the precision of your target. Gamma knife uses multiple non-coplanar simultaneous beams while LINAC delivers the dose in fields in the arcs. That's why the dose delivery in gamma knife is very unique with a very minimum dose fall off outside the target. LINAC, which is commonly used by the radiation oncologist, is commonly used to deliver a single fraction of the hypofractionated treatments. CyberKnife, for all practical purposes, 1 millimeter margin of error is more reasonable to expect. LINAC is typically delivered in hypofractionated regimes of 3 to 5 fractions. And according to the pathology, you decide the dose per fraction with an interfraction interval of close to around 24 hours. Usually for vestibular schwannomas, they consider it 18 to 24 gray in 3 fraction or 20 to 25 gray in 5 fractions. A LINAC has several moving parts, which increases the potential of inaccuracies. And this is, of course, of utmost importance to consider when treating targets inside the brain. This is a new LINAC-based machine, which is the gyroscopic radiosurgery, which is called the ZAPX, and it has significantly improved in comparison to its earlier LINAC-based counterparts, especially the CyberKnife. The mechanical accuracy is now submillimetric, but is still the sharp dose fall-off and the mechanical accuracy or gamma knife are slightly better with it. Because the source to the target distance is least with the gamma knife, that's why the penumbra and it's with its particular 50% isodose fall-off, the dose gradient are extremely steep in gamma knife, providing you an accuracy of the treatment delivery while sparing your neighborhood. It's very natural to have these questions in mind. So which particular SRS platform should be used? And sometimes it's complicated enough to frustrate you. Paddock published this data for his benchmarking evaluation of the contemporary SRS platforms. He is convinced that equipments have refined and the planning systems have improved significantly. They have become faster, sophisticated, but having these technological improvements, did it translate into the corresponding improvement into the clinical outcomes and in making the treatment plans better? He evaluated all these parameters with the collimation, their module, their delivery technique, and their intrafraction imaging. And he finally concluded that planning indices are generally improved, especially with the C-arm based LINAC. Planning and treatment times vary dramatically between the technologies, but still the Cobalt 60 and the 3MV still appears to yield a superior gradient for small targets compared to the other LINAC-based techniques. So the gold standard is still with the gamma knife radiosurgery, but there is a dose fall-off. And then comes the question of the biological effective dose. As the source gets older, the dose fall rate of gamma knife platforms reduces and the treatment duration increases. The treatment delivery time in SRS affects the biological effect for a given physical dose due to the sublethal DNA damage repair processes. Sadly, the LQ model, which is actually the backbone of any radiosurgery planning station, tries to overestimate the BED delivered. My friend Konstantin Tuleska championed the concept of the biological effective dose, and now there is a growing controversy whether the physical dose should be measured or the biological effective dose should be measured. There are certain LINAC-based platforms which are delivering radiation very fast, like the TrueBeam. It is significantly faster than CyberKnife or Gamma Knife. And in those cases, if you consider the similar dose of 11 gray, 12 gray, 13 gray, then probably you might be doing more radiation delivery to your target, leading to higher complication in those patients. So do you need a plan which is hot at the periphery, or do you need a plan which is hot in the center but cold at the periphery? Being hot for a benign pathology like schwannoma is not a good option. Even prescribing with this similar 12 gray, TrueBeam is delivering a significantly higher biological equivalent dose, effective dose in comparison to the gamma knife. And then in those cases, your peripheral structures are getting much higher radiation exposure, like in the brainstem and facial nerve and trigeminal nerve, and that is leading to the complications at a short term in these patients. So now looking at this ongoing discussion, different treatment modalities, their short delivery times and the interval between shots, we are certainly entering into an era where the ISO-BED plans would be in practice rather than the ISO-dose plans. So if you are comparing different machines, rather than looking at their ISO-dose plans, you need to look at their ISO-BED plans, and then you need to treat your patients on the ISO-BED parameters rather than the ISO-dose parameters. I was earlier an author of these comparative platforms, which we published for the Gamma Knife Radiosurgery issue of Neurology India. And the interested readers can actually go through different parameters on which different radiosurgery platforms work and in the differences over them. Now I come to the Proton radiosurgery, in the skull base, the black peak has a potential disadvantage. We know the black peak that the radiation doesn't have any exit dose and all of the radiation is deposited at one particular area. But in the skull base pathologies, the proton beam penetration is more erratic and less consistent than in the supratentorial intraaxial lesions. The highly variable density of tissue in the beam's path, such as the mastoid air cells and the otic capsule, they cause lateral scattering of the protons and unavoidable range uncertainties. So if the energy peak occurs at the perimeter or outside the target, then there is a chance of a significant radiation toxicity to the normal tissues. As we just heard talk by Dr. Manas Panigrahi, in some of the articles of the proton radiosurgery, the facial nerve deficit has been observed to the tune of 28%, which is significantly high in comparison to the other radiosurgery platforms. What are we aiming with radiosurgery? Progression-free survival, overall survival, free from additional treatment, while maintaining the hearing, preserved smile, functional facial nerve, and while minimizing the chances of radiation-induced complication inside the brain, and while minimizing the extracranial dose distribution of the radiation. This is a retrospective analysis of long-term outcomes of single-session SRS between gamma knife and LINAC for more than 6,500 vestibular schwannoma patients. The tumor control rate across the studies were found practically similar between GK and the LINAC SRS, and hearing preservation rate was also similar, but the trigeminal nerve function and the facial nerve function was significantly better in gamma knife in comparison to the LINAC-based techniques. The tinnitus in this study was found to be a better responder to LINAC rather than the gamma knife. Overall, if you look on the long-term data and the studies, systematic analysis, review, and the meta-analysis, the tumor control was found practically equivalent between gamma knife and LINAC, slightly better than the proton radiosurgery techniques. Initial enthusiasm for SRS stemmed for its promise as a potentially less invasive modality that permitted the hearing preservation. Although reports indicated good short-term hearing preservation rate, I agree with Dr. Manas and Dr. Misra that evidence indicate that the rates of serviceable hearing at 5 and 10 years or beyond are less encouraging across the various radiosurgery platforms. And down the line 10 years, the chances of maintaining your functional hearing preservation are not more than 30% in the systematic reviews. The factors for the hearing preservation have been identified to a certain extent. Like they are better in the young people, patients with the preserved hearing, when your cochlea can be preserved from 4-grade radiation exposure, and when the tumor gets 11 to 12-grade radiation. The main important structure is actually the basal turn of cochlea, which houses the outer inner hair cell, and we try to preserve it. And this was a landmark study which started the cochlear dose era. It was by Marce group by John Regis. And they published that if we are able to preserve the cochlea from 4-grade radiation exposure, the chances of long-term hearing preservation are significantly better. And then came over-enthusiastic radiosurgeons who tried to preserve cochlea from 2-grade or 3-grade radiation exposure as well. But the results were not much different in comparison to the 4-grade study. I find this study and this classification by Ohata much practical in my ability to preserve the cochlea and chances of maintaining a useful hearing for a longer duration of time. If the tumor is extending deep inside the internal auditory canal and you are not able to find a CSF arachnoid cap, you are able to see it in the type C. There is a CSF arachnoid cap. In those cases, the chances of sparing your cochlea while treating the complete tumor are significantly high. But if the tumor is deep inside the internal auditory canal, then the chances of preserving your cochlea are less. And in those cases, the hearing outcome is actually not that robust. Hence, there came a question of hypofractionating vestibular schwannomas. And this is a recently published article in International Journal of Radiation Oncology and Biophysics. It was the first double randomized controlled prospective trial with the cyberknife radiosurgery over 10 years duration with a minimum follow-up of 36 months. They compared the single fraction and hypofractionation in 3. In single fraction, they tried to preserve maximum point dose cochlea to 4-gray, and in hypofractionation from 10-gray. And they concluded that tumor control, hearing preservation, everything was exactly the same. And I'm happy to say that there is no advantage of hypofractionation in vestibular schwannoma by any technique or by any machine. The problem with the hearing outcome is that we couldn't understand the complete reason of the hearing loss in patients with vestibular schwannomas. Many a times the tumor does not grow, but the patient loses hearing. So there are multiple complex pathologies pathophysiologies are actually taking place over there, which include mechanical compression, secretion, vascular, even the immunobiological effect in the endolymph, perilymph, and the basal tone of cochlea, which dictate the outcome, and some answers are need to be given. So the hearing loss after radiosurgery, if you want to blame it to the cochlear dose or to the radiation tool, probably you are not going to get a correct answer at present. An important factor, one of the major troubles with vestibular schwannoma is vertigo, and it shows that there is some change on their own with the observation. Irrespective of the SRS technique, there is no improvement in the vertigo. On the other hand, there might be acute worsening with surgery as it ablates whatever the residual function is preserved. Therefore, avoidance of the expected vestibular symptoms after microsurgery may steer the recommendations towards SRS, especially for those individuals who may not compensate well, such as those with the poor vision or the Parkinson's disease or peripheral neuropathy. So in addition, much scrutiny has been placed over these two techniques, as the literature is practically 75% with the gamma knife, around 20% with LINAC, and 5% with the proton radiosurgery. We have found that the tumor control and hearing preservation are nearly the same with gamma knife and LINAC, but the facial and trigeminal nerve function are significantly better in gamma knife radiosurgery techniques. The chances of having a facial nerve dysfunction are significantly high with the hypofractionation, especially with the proton therapies and with the linear accelerators. Similarly, the chances of trigeminal neuropathy is much higher, which leads to the numbness over the face with the LINAC-based techniques. Apart from it, we need to look, while we are treating these tumors, we do not pave a way for creation of the new tumors over the long course of time. With its sharp dose fall-off, the chances of extracranial radiation exposure are close to 5 to 130 times lower with gamma knife in comparison to the Cyber knife and the LINAC-based technologies. So that is because of the sharp dose fall-off and the low energy source of gamma knife and the ZapX machine. They reduces the scatter and they decreases the chances of the radiation exposure because of their shorter distance from the source and the target. If you look at the long term, and the complication and the chances of extracranial dose and the risk of radiation-induced malignancies, they become practically 40%, 2.2 to 40% with the Cyber knife in comparison to 0.03 to 0.88% in comparison to the gamma knife. And this becomes a very important concern once your patient is young. They have a long life to live. Then to reduce and minimize the chances of the radiation-induced malignancies, probably you need to choose your machine wisely. This is an important remark after this benchmarking study by Ian Paddick, which he gave at ISRS, that the gamma knife plants were consistently the best performers in terms of conformity and particularly markedly steeper gradient outside the target. But I would like to add one more thing over here, that with this new planning softwares and the inverse planning, many times you should make a hybrid plan to tweak those inverse planning plans, because those look good, but sometimes they become hotter at the periphery. So you need to look at the dose delivery in a practical physical dose distribution as well. This is again proton versus photon versus LINAC compared to the most currently practiced SRS techniques. Proton radiosurgery does not offer advantage of the facial and the hearing preservation. To counter this, there was a wonderful comparative evaluation in which they did a cochlear optimized treatment planning in photon and proton radiosurgery for vestibular schwannoma patients, and they could conclude that you can achieve a cochlear dose reduction with the cochlear optimized plan without compromising tumor coverage with both photon and proton. But in proton radiosurgery, it does not translate into better tumor control or hearing preservation in the long term. Again, fractionated proton radiation therapy has not met the goal of serviceable hearing preservation in this phase 2 clinical trial published in neurosurgery. And this I have borrowed from Lunsford. In this era of these sophisticated stereotactic radiosurgery techniques, there is no advantage of fractionated radiation therapy for vestibular schwannoma. They are less accurate radiation techniques. They deliver lower biological tumor dose. They reduces the rate of the tumor regression, and they come at a much higher rate of the hydrocephalus, and they are very inconvenient. A treatment delivery which can be done in a single fraction and a single day, why should we irradiate somebody over 2 or 3, 4 weeks duration? So the tumor outcome is same, control is same, but you are going to have the functional outcome by their facial nerve preservation, trigeminal nerve preservation, vertigo, hearing. So it's not just about hitting the right target, but also about the missing the rest. As far as photon versus proton is concerned, I would say that proton carries a significantly high financial toxicity without giving any real-time benefit in comparison to the photon and the LINAC-based ones. And there is no need to fractionation for a disease which can be treated in a very short hospital stay as a daycare procedure. Why there should be a need for the hypofractionation if we do not get any significant improvement? And while we discuss all these things about the hearing preservation, various studies have shown that the functions, the factors that determine the quality of life is not the hearing preservation. If the person is having another functional ear, then the quality of life is dictated by vertigo, tinnitus, headache, imbalance, and the facial nerve preservation. This is our own study, and this was a PanQL quality of life assessment for the Hindi speaking population. We realized that the quality of life is affecting vestibular schwannomas is unlikely but significant if it occurs with the brainstem injury and facial nerve injury, and it is more likely but less significant on quality of life with the unilateral hearing loss and pseudoprogression. So to conclude my talk, I would say that treat the tumor but not create the one. Any new tumor over there. Tumor control is same irrespective of SRS technique, SRS machine. Hearing preservation is also same irrespective of the SRS technique and machine. But the facial nerve and trigeminal nerve are significantly better in the gamma knife. We have different modalities. It's not actually exactly the machine always. It's the person who is actually sitting behind the machine. And you shouldn't add any margin to that. That's why I say it's trust your machine, and you can have excellent results with an inferior machine, and you can create devastating complications with a good machine as well. So bet on the jockey, not just on the horse. Thank you so much. This is my radiosurgery team at PGI Chandigarh. And thank you to Professor Shihan, Dr. Niranjan, and Dr. Paddock, and Danny Nexel, the son of Lars Lexel, for guiding me for this. Thank you so much. Have any questions? If Dr. Vincent, somebody?
Yeah, hi, Dr. Manjul. There's actually 4 questions at the Q&A side.
I'm not able to see those ones.
Maybe I can help. I think the first question was by Dr. D.M. Arman about facial nerve preservation tips, Dhaka.
In surgery.
Yes, that question came in during surgery.
Okay. So, Dr. Misra, Dr.
Manasale, go ahead.
Yes, sir.
Okay, so what I think is number one is not pulling on the nerve and staying in the tumor arachnoid plane. You know, there is always a lot of concern when you are, whether it is nerve, especially large and giant tumors, what is nerve and what is, some fibers or tumor fibers. So if you have a doubt about where is the nerve and if that have you reached the nerve and tumor interface, it's always better to err on the side of tumor. Leave a little bit of tumor attached to the nerve, because we know that if you have taken out the vascularity of the tumor, the small strands of the tumor on the nerve does not grow most of the times. And even if it grows, you can always have some adjunct treatment later on, because it's critical to have a good function today. I think that's very important, number one. Number two, both myself and Manas has emphasized the risk of heat injury when you are doing intra-aortic canal. So if you want to drill intra-aortic canal, lot of irrigation, all the time irrigation. And when you are reaching the nerve, you know, to have a lot of decompression of the tumor. Do not try to, kind of separate the tumor from the nerve when there is a tumor bulk is still there. So significant decompression, but don't go into a very thin wall. You know, if you very, very thin capsule, when you are trying to dissect, you will lose the capsule, you'll tear up the capsule. So I would say about few millimeter, 3 to 4 millimeter capsule, leave it, and then try to stay away from the nerve. So lift the tumor off the nerve rather than the nerve of the tumor. And one of the tricks, especially large and giant tumors, is lift the tumor from the lower end start from the medial end and start at the root entry zone or root exit zone for the facial nerve, or root entry zone of the hearing nerve, which is about 2 to 3 millimeter above the root entry zone of ninth, 10th, which is much easily found, and just anterior to the choroid plexus. Start from there. And then if you lose the plane, leave that and go back to some other plane. Don't keep on, kind of following that. So these are the key points. Number one, never try to pull on the nerve. Number two, leave a thin sliver of the tumor if you are worried about where you are. Try to stay in the tumor arachnoid plane. A lot of irrigation while drilling, and some adjuncts like which we showed, the use of sodium fluorescein to differentiate from tumor and the nerve. The tumor enhances, the nerve does not. And if you have a large tumor, sometimes, it gives us an idea about the displacement of the nerve if you have a pre-op DTI. Manas, you can add on anything.
No, nothing to add, sir.
Dr. Manas, with this, as you used endoscope as well with the microsurgery, sometimes this endoscope causes a heat injury. I remember one of your talks when you gave a particular talk on the endoscope induced heat injuries during intraventricular procedures. Do you find any such incidents here?
That depends on the duration of endoscope used, and because here it's a very short duration, and also the distance from the working distance of the tip of the endoscope to the target. So here it is larger, and here and we use for shorter time. So heat injury is not an issue, and and you can always come out intermittently, and so that is not an issue. Unlike pituitary, where you keep it for longer time, and that we are more worried about the pituitary dysfunction because of heat injury.
Dr. Vincent, any other question by panelists or
Yes, actually,
Some questions in common.
there's a question by Dr. Asim Pradhan on the Q&A site about intraoperative implantation of the cochlear implant. Is there any prognostic factor we can consider for success rate of hearing preservation, dissection techniques, BAR, or monitoring? I think that may be to Dr. Manas for the intraoperative cochlear implantation. There any prognostic factors for success?
Yeah, means that was the paper published, and so if you can preserve the wave 1, 3, and 5 during your surgery, it is preserved. Then one can go for the intra simultaneously after tumor excision and intraoperative cochlear implant. We don't have an experience. That is what was quoted. So that will be a next step. Rehab procedures for patients whom we are operating for hearing preservation.
Thank you. I think Dr. Manjul has left the screen for a while. Maybe I see Professor Tu on screen, and Dr. Igal. Do you have any comments or questions on the tree presentation thing?
Now, there is one question for Dr. Manjul, I think. When gamma knife radiation should
Oh,
not
yes.
be
Dr. Manjul is now back. I can then ask Dr. Manjul. Dr. Manjul, you have three questions regarding gamma knife, actually. One is what is the indication, what is the cost, and when is it not necessary to use gamma knife radiation?
Sure. So first I'll go with the indication. The standard indications are now Coos grade 1 and 2 vestibular schwannomas. Coos grade 3 and 4 are actually need to be decided on the patient-centric approach. If the patient is an old one and it's a Coos grade 3 vestibular schwannoma, patient has no clinical compressive features, those patients, even while being a Coos grade 3 or Coos grade 4, you can treat with the vestibular schwannoma. Earlier, it was considered that the cystic vestibular schwannomas do not respond well, but if it is an intratumoral cyst, it's not an arachnoid cap, those tumors also respond well. You shouldn't use radiosurgery in cases when you have a clinical compression or a gross radiological compression. The larger is the tumor, the chances of radiosurgical failure are high. So it's always better to treat only Coos grade 1 to 3. As Dr. Misra also told about the large vestibular schwannomas, with an upfront primary radiosurgery with the recently published ISRS guidelines, those patients were the one who were just having a radiological compression but not clinical symptoms of the vestibular schwannoma. The second point I would like to say that if the patient is coming with a trigeminal neuropathy, it's always better to go with the microsurgery in those patients. Patients who are coming with the vestibular schwannoma and a trigeminal neuralgia, because the patient needs a pain relief. For vestibular schwannoma, after radiosurgery, it's going to take a long time, and probably the volumetric reduction wouldn't be that robust, and the patient would be in the pain for such a long duration of time. There is no point in keeping patients over drugs. In those patients, going with the surgery with your planned resection and decompressing your trigeminal nerve, that gives you the best outcome and the best quality. The second part was if you, and one more thing, if you have a doubt in the diagnosis, though in vestibular schwannoma, the radiological appearance is a very characteristic, but if you have a doubt in the diagnosis, never go with an upfront radiosurgery. As far as the cost is concerned, this is very variable across the world, and in India, it can be done at cheapest at $1,000, but in private sector, this can be treated by around somewhere around $3,500 to $5,000. And in USA, the cost of treatment is significantly high, close to around 20 times high, which we treat in India. So that depends on the place where the people are getting treatment. I forgot the third question. You need
I
to.
think you have answered most of the questions.
Yeah.
Yeah. Thank you. I think Professor Igor has his hands up.
Oh,
Yes, hi, thank you. All your talks were very good, excellent. I always learn something from everybody. Misra, the question for you, I always bothered about the issue of scan and watch, or watch and scan, or whatever you call it, and how to select the patient for follow-up and not for treatment, regardless of the modality of treatment, okay? How to select them, how to follow them. And what is your experience? I mean, do we have any clinical or radiological data that may support follow-up rather than offer treatment, upfront?
Yeah. So patients, they're intracanalicular or small vestibular sonomas, whose 1, 2, are not uncommon being picked up for a patient has a headache, patient has a trauma, they pick up incidental pickup. Now, patient comes to me and because imaging wise they have a diagnosis, they are always candidates for follow. The other one is a patient who has only minor problems, like, for example, tinnitus. And he's been evaluated, hearing is good, and he comes for follow-up. He comes for an opinion, intracanalicular tumor, always. Every single patient goes for an observation. Now, I just showed you, I don't know, you missed it. There is a 2024 publication comparing weight and watch and scan, or something, weight and scan, they call it WAS, weight and scan, and or watch and scan, and compared to radiosurgery. All aspects, the hearing, the functional quality, the pan-QL, everything was better in watch and scan. This is 2024 publication meta-analysis. So I have no concern. The problem in our country is loss to follow. But the intracanalicular acoustics, I mean, across the board, all studies, all series, none of the series show that the rate of treatment is more than 50%. Most of them are 60, 65%, do not need treatment, right? So when you are advising upfront treatment, you are treating 65% of the people, who may not need treatment in their lifetime. Now, one of the major differences between upfront treatment and observation and follow-up is the hearing problem. Now, the thing happens with hearing deficit in wait and watch is so slow progression. The patient, most of the time, are not even aware they have a hearing loss, right? Whereas if you do surgery or you do gamma knife or radiosurgery, whatever, the microsurgery hearing drop, whosoever drops, even the one of the best series, Coldwell is currently probably the best series in the literature, 22% would drop the series. Now, if you go to the full article of Coldwell, now that 130 or something odd cases, even their first is observation. Only patients who drop hearing or they grow, they treat. So if you don't read that, if you just read the abstract, it looks like if they're advising microsurgery for all intracanalicular tumor. No, they have a period of observation. Only when there is a drop of hearing, they go for early radios. They don't wait for hearing to drop very much. Slight drop, they had advised surgery because they have about 78% of hearing preservation.
And how many of those?
Another group of patients, not the intracanalicular, these small acoustics or even 2 centimeter, 2.5 centimeter tumors, elderly patient who have a long period of hearing, kind of progressing history of loss of say maybe 15 years, 20 years, 70-year-old comes to you with hydrocephalus. We don't operate the tumor. We don't give radio. So we just do a shunt. I have a series of patients where there have just been a shunt and the tumor remains static. So I think there is a group of patients who do not need attack to these are benign tumors, right? And I think one of the greatest the pluses of radiosurgery, gamma knife radiosurgery, that we realized many of these patients do not need treatment. Many of these intracanalicular tumor before the radiosurgery. I mean, I have traveled many centers, best centers in the vestibular schwannoma in the world. They used to search for the tumor in the canalicular. We never had that because we never picked up those patients. But they used to search for it and remove it, which now we realize many of them do not need treatment in their lifetime. So one of the greatest pluses I tell as a joke is radiosurgery, gamma knife, is to realize that the 2000 publication that many intracanalicular tumors do not need treatment.
And
answered your question?
what about the sudden onset of hearing?
Yes.
Or hearing loss that happens in some of the patients.
It's
You
only
follow
less
them
than
and they
2%.
come overnight and they require a course of
Eagle,
therapy.
the incidence is less than 2% sudden loss. The largest series from house group is less than 2% sudden loss. So you are treating for 100 people from whom the loss is only 2% sudden loss. And there is no guarantee that you will not have a sudden loss after radiosurgery or microsurgery.
Thank you. Professor Tu, you raise your hand.
I do agree with the Basant that small incidentally found tumor intracanalicular do not need to be operated or do not need to be treated by radiosurgery. But the other condition is for a larger tumor, you remove it subtotally, a small portion of tumor remain there. For those kind of patients, do you need to perform radiosurgery immediately or you was observed for a certain period of time? Because we have many cases, we try to remove a tumor, but due to a severe adhesion of tumor to the nerve, a small piece of tumor remained there, and we did not treat the patient any further, just observe the patient, and the tumor is not growing. So I like to know the person thought about this particular condition.
Yeah, I agree completely. In fact, I emphasize that many times, especially the enhancing component, and Manas also talked about it, that in fact, some of these are post-op changes, the enhancement which you see at that, and sometimes they reduce because probably even if some tumor is there, you have taken off the vascularity, the tumor probably necrosis. I don't know. But we have a number of patients where we haven't, and we never are in a hurry. If the small tumor part is left, we are not in a hurry ever to give radiosurgery. We have a period of observation. We see the growth and they go for radiosurgery. But of course, the major problem, as I said, in our country is loss to follow-up. They lost to follow-up and they come back with a large and giant tumors. That's a problem. So if your follow-up is not suspect, it's quite appropriate to have a period of observation, even if you have a residual tumor. I agree completely with you. I think that follow-up loss probably is not a problem in Professor Tu's place. I mean, your country and people, I think they would come back for treatment. We have economic problem. They travel hundreds of kilometers to come for treatment. They don't come back again for follow-up. So that's a major problem.
Can I add something? So we published on this residual tumor. I mean, not we did MIB index for all of them, and we found a statistically significant difference that tumors which had more than 3% had a higher chance of recurrence. And then now we did another study, did a proteomic study between the groups which had a recurrence and no recurrence. and we found there are certain proteins were expressed more in the tumors which regrow, and so that's a thesis done by our resident. We have to publish. So the proteome, if you do proteomics of the tumor tissue, you can predict that a particular patient will recur or not.
Thank you. There's one more question for Prof. Prof. Basant. How do you perform sharp dissection, by using scalpel or dissectors?
Manas, go ahead, please.
You use a sharp dissector. You use a needle. Means if you have diamond knife is good, or any sharp instrument, not means scalpel, because scalpel has a longer blade. There are chances of damaging adjacent structures. But using a needle or a diamond knife is good. Then a blunt dissector.
Vincent, Dr. Grossman is there. He may have some comments.
Yes, Prof. Grossman, do you have any comments or anything you would like to mention?
Just want to say thank you for this great webinar. Thank you, Manjul. Thank you, Basant. Thank you, Manas. The next webinar will be on the peripheral nerve sheath tumor, and will be organized by Deborah Grozzo, and it will take place on the 18th of July. So we probably will have the promotion on the e-platforms and the socials, so you're more than welcome. Yeah.
Yigal probably wants to say something.
Thank you.
Dr. Yigal?
As you know, just a comment, not a question. You know, you guys showed very nice the evolution of the management of vestibular schwannoma along the four decades, and there are still many questions that are open. You know, we're talking about this and that, and there are so many questions that are still open, and we don't really know the answer. So, and you know, and we're facing a very exciting time now with smart algorithm that runs multiple data on vestibular schwannoma, clinical as well as radiomics. And I believe that in the very near future, we'll start to get some questions to those many open questions that we have based on those algorithms. I'm quite optimistic with that. We are personally running a big study on that, incorporating clinical as well as radiological longitudinal follow-up for vestibular schwannoma, and trying to do the prediction. And then when the patient first come to your room, based on the MRI, the radiomics, and the clinical picture, he will say he will be fine with follow-up to the rest of his life, or maybe he will require something now. Because in 2 months from now, he will have a sudden drop of hearing loss or something like that. So just a comment, we are just about to hear more and more about that.
Thank you, Yigal. And I would like to...
AI and big data.
Yeah.
Thank you. But recently, the CNS published their consensus guidelines on the management of vestibular schwannoma. It's actually an update of 2019 guidelines, and they have added certain new level of evidence. And if you remember, it was published in 2019 in Neurosurgery. There were some 7 articles over it, which covered practically all the types of the management of the vestibular schwannoma technique. And they made some important comments, like if a patient comes with tinnitus, then the chances of that patient having a progressive tumor kept under observation are significantly high in comparison to a patient who does not present with that tinnitus. So how does that tinnitus become a prognostic factor? We do not know. The second point about the observation, keeping under observation, sometimes as the patient does not come back, and if we are not able to do a co-registration of the images, we miss the initial chances of the growth. And then suddenly, once the patient, after initial some 2 or 3 years with the observation, they come after 1 decade, the tumor is suddenly large in size, and then apart from the surgery, there is no other option. So if you want to keep the patient under observation, that has to be with the co-registered images, because any growth is a growth. Even if there is a 0.5 millimeter growth, that tumor has a tendency to grow, and probably in that observation, you have a particular subset of patients for which you need to be much more vigilant. And I still do not have an answer to this question that if a 35-year-old patient with a Coos grade 2 vestibular schwannoma with a serviceable hearing comes with asking me the most durable option, so should I recommend radiosurgery, or has surgery come back as a staged as a comeback in these selected young patients? These types of questions, which usually the patient asks these days, becomes very difficult to answer because we do not have a level 1 evidence to all these questions. But I hope the audience must have got new information.
I just want to make a point. There's a lot of confusion, and because the literature is what has happened, even the meta-analysis, some of them combine the COOS 1 and COOS 2. I think COOS 1 and all other COOS are completely different. COOS 1 is a different beast. COOS 1 is a very indolent tumor, whereas COOS 2, all these problems, the risk of COOS 1, even the last meta-analysis, the JAMA, that was also combination of COOS 1 and 2. So that creates a problem. You take COOS 1, the risk of having, except hearing deficit, the risk of the growth and producing a problem, even if you miss for 2-3 years, is very, very little. I mean, now that I'm there for 35 years, I am yet to see a COOS 1 tumor which has become a giant tumor ever. They grow. Some of them do grow, and there's no question about it. In fact, one of the first publication is the guy called Rout, R-O-U-T, from Canada, and who published the first series of no growth for a period of 7 years. And that was Canadian data, which is very, very reliable, because there's a controlled environment. There is no financial incentive at all. So that was a very impressive data. So COOS 1, I think they combine COOS 1 and 2, that's a problem. COOS 2, all these problems, loss to follow, these things and that thing. COOS 1, only problem is hearing, nothing else.
So if the tumor is peeping into the cistern, you need to be careful. If it is
absolutely,
the cistern, you can be sure. Any other question? Any comment?
There's actually an important comment that's posed to the host and the panelists from Afghanistan. Maybe I'd like to draw attention. Maybe not, I can't read out the message because it's actually to the panelists, but I think there's a message that everybody should take a look at from Afghanistan. Thanks. And see whether we would like to respond to the comment.
Which one is it?
It's on the chat.
Donation for radiosurgery to Afghanistan.
I like to attention, unfortunately, to political. We haven't the possibility of management, especially possible sub-donation equipment training for Afghanistan. Training is possible. I think this audience or this faculty is not capable of donating a radiosurgery.
Yeah.
None of that. We have that capability. Training, of course. I mean, we're very happy to help in case somebody is interested. Do write to any one of us. All three, the panelists have Gamma Knife now. So please do write to us, and we will be very happy. Right now, I have a guy from Africa with me. He's going to stay with me for 1.5 years now. Not Gamma Knife, but everything else. I mean, neurosurgery. So we have all the time. We have some 1 or 2 young neurosurgeons from somewhere in the low and middle income countries. So we are very happy to support. There's no problem at all.
Thank you.
Dr. Vincent, I think we have exceeded the time. So now,
and you would like to close the session?
So thank you so much. Thank you, Professor Misra, Professor Manas, for this wonderful talk. Thank you, Vincent, for helping me in organizing all this, and Dr. Yigal, Dr. Grossman, for being a pillar of support for me. Thank you so much. And
Dr. Tu, and Dr. Tu also there. Yeah.
Yes, Dr. Tu, yes. A senior neurosurgeon. It's good to see Dr. Tu here in the audience today.
Thank you. Thank you, Manjul. Thank you. Well done.
So welcome, sir. And we'll meet again on 18th July for the peripheral nerve sheath tube. Thank you so much. Have a good day.
Thank you.
Bye-bye.
Bye-bye.
Bye-bye, everybody.
Stay safe.
Stay safe.